Welcome back to the deep dive. Today, we're really digging into something quite complex. Primary liver cancer. You might also hear it called hepatocellular carcinoma, or HCC.
That's right. And we're doing this specifically for you, our listener, based on some really useful material you shared, excerpts from Dr. Ghassan Abu Alfa's book, 100 Questions and Answers about Liver Cancer.
Yeah, it's a great format, that Q&A style. Makes it feel more approachable.
It really does.
Right.
So our mission here is basically to unpack these excerpts, pull out the core information, the key insights, and help you get a solid understanding quickly. Covering the basics right through to treatment and coping strategies.
Definitely. It can seem daunting, I think, but we'll walk you through it, highlighting what the source material emphasizes. Consider it a guided tour, maybe, a shortcut to getting informed on this.
Exactly. A focused look based on these specific questions and answers.
Okay, let's jump right in then. Starting super basic, according to this material, what is the liver?
Okay, so the liver, fundamentally it's a large organ, one of the biggest actually, and it's made up of these tiny units called cells. Think of them as miniature factories.
Factories doing what?
Well, countless essential jobs, really. They produce vital substances, enzymes, hormones, antibodies, things your body absolutely needs. Plus, they're like a filter, cleaning toxins out of your blood. Super important.
Okay, vital organ, tiny cell factories. The material defines cells as the smallest structural units. So, what happens when cancer develops in those liver cells?
Right. So cancer, at its heart, is uncontrolled cell division. Normally, cells grow, divide, and die off in a very controlled way. But with cancer, a cell basically goes rogue. It starts dividing and dividing, ignoring the stop signal.
Just dividing like crazy.
Well, yes, but it's more than that. These cancer cells often lose their original liver functions. And worse, they gain new, destructive abilities.
Like what? What kind of destructive abilities?
They can start invading the healthy liver tissue around them, or even nearby organs. They're also really good at hijacking the blood supply, stealing nutrients from normal tissue. Sometimes they even trick the body into growing new blood vessels just for them.
Wow.
And the really dangerous part is metastasis. That's when these rogue cells break off, get into the bloodstream or the lymph system, travel somewhere else in the body, and start a new tumor.
Right, metastasis, the spreading. So if cancer cells are doing all that, are all cancers found in the liver actually liver cancer? The material makes a point about this, doesn't it?
It does, and it's a really critical distinction. When doctors say primary liver cancer, they mean the cancer started in the liver itself. HCC, hepatocellular carcinoma, is the most common type that starts in the main liver cells, the hepatocytes.
Okay.
There are rarer types too, like cholangiocarcinoma starting in the bile ducts or hepatoblastoma in kids, but HCC is the main focus.
So primary means started there.
Got it. Exactly. Now, secondary liver cancer is totally different. That means the cancer started somewhere else, maybe the colon or the breast or the lung, and then spread to the liver. Metastasis to the liver.
Ah.
And doctors will always call that by its origin. So breast cancer that spread to the liver is still called metastatic breast cancer, not liver cancer. It's a key point from the source because the treatment is completely different.
That makes sense. Very important distinction. Okay, so we're focusing on primary liver cancer, HCC. Who's most likely to get it? What are the risk factors?
Well, what's really striking, according to the book, is that HCC rarely just happens spontaneously. It's almost always linked to some kind of pre-existing liver problem or abnormality.
Like what kind of problem?
The material lists 6 main reasons your liver might be abnormal and increase your risk. First, chronic infection with viral hepatitis B. Second, chronic viral hepatitis C. Third, long-term heavy alcohol use.
Okay.
Fourth, conditions like obesity and diabetes are increasingly recognized. Fifth, certain inherited metabolic diseases. And sixth, sometimes specific environmental factors.
How do those things actually, lead to cancer? What's the mechanism?
It seems to work in a couple of ways. Some factors, like hepatitis B, can directly cause genetic changes in the liver cells that promote cancer. But more often, these factors cause chronic, long-term inflammation and damage, year after year of damage.
Leads to scarring. Is that cirrhosis?
Exactly. That severe, widespread, irreversible scarring is cirrhosis. It's not just a little scar tissue. It replaces the normal liver cells throughout the entire organ.
Right.
It disrupts the liver structure, its function, everything.
And it takes a long time to develop.
Oh yes, years, often decades of continuous damage. And the material really emphasizes this. Patients with cirrhosis are at a particularly high risk for developing HCC. Although it's worth noting, some people do develop HCC without having full-blown cirrhosis. It's less common, but possible.
Okay, so cirrhosis is a major pathway for many, but not all cases. Let's dive into viral hepatitis then, B and C, since the source really highlights them.
Right. So hepatitis just means liver inflammation. Viruses are a common cause. A, B, and C are the main ones discussed here. You can have an acute infection, which is recent. Hepatitis A, for instance, usually clears up completely. People recover, and they aren't at higher risk later for cirrhosis or cancer from it.
But B and C, they can stick around.
That's the crucial difference, yes. With Hep B and C, for some people, the body doesn't clear the virus. It becomes a chronic infection. It just persists. And those patients, the ones with chronic Hep B or C, are the ones at significant long-term risk for liver damage, cirrhosis, and eventually HCC.
How significant is the risk? Does the book give numbers?
It does give some estimates. For chronic hepatitis B, the risk of developing liver cancer is roughly 0.5% per year. For chronic hepatitis C, it's a bit more complex. After exposure, maybe 55 to 85% develop chronic infection. Of those, about 20% eventually get cirrhosis. And of those with chronic infection overall, around 5% might develop liver cancer.
How do people usually get these viruses?
Well, historically, hepatitis C was often spread through blood transfusions, especially before 1992 when widespread screening started. That's rare now in developed countries. Today, it's more commonly linked to sharing contaminated needles, like with IV drug use, though healthcare workers can also be at risk. Hepatitis B is also spread through blood and body fluids, things like sexual contact or even from mother to child during birth.
Yeah, the book actually shares a story from Sam Howe. His father probably got Hep B from a transfusion as a kid in Asia, where it's much more prevalent. It highlights that global variation. Sam mentions his family was told back then there wasn't really a cure for the virus or the cirrhosis, and maybe they didn't fully grasp the cancer risk that came with it.
That's tough. But are there better treatments now for chronic Hep B and C?
Oh, absolutely. Huge progress. For chronic Hep B, we have antiviral medications. They don't always fully cure it, but they can dramatically reduce the amount of virus in the body, which significantly lowers the risk of cirrhosis or cancer developing. And treating the Hep B virus is still vital, even if someone does develop HCC.
And Hep C has seen a revolution, really. New direct-acting antiviral drugs, you hear names like Harvoni, Isapetier, Mavorette, they can actually cure the Hep C infection in most people, completely eliminate the virus.
Right.
But if you cure the virus, you essentially eliminate the future risk of it causing cirrhosis or cancer.
That's amazing.
It is. But there's a slight complexity the material points out. If someone already has liver cancer, using these powerful Hep C drugs is still a bit debated. We don't fully know the safety or potential interactions with cancer treatments yet. Also, it's important to remember, even with Hep C, it can take a long time, like 10, 20, even 30 years after infection, for cirrhosis and cancer to show up.
Okay. What about the other big risks mentioned? Alcohol, obesity, inherited stuff.
Right. So alcoholic liver disease comes from chronic, heavy drinking. The amount and duration really matter. The source gives an example like 60 to 80 grams of alcohol daily, which is about 6 beers or 6 ounces of hard liquor, day after day. Women are often at risk with less than that. A common early stage is fatty liver, but that can progress to cirrhosis and cancer over time.
And obesity and diabetes.
Yeah, this link is becoming much clearer, especially in the U.S. Being diabetic or severely obese definitely increases HCC risk. It's often tied to something called NAFLD, non-alcoholic fatty liver disease. That can progress to NASH, which involves inflammation, and then potentially to cirrhosis and cancer. It's a growing concern because obesity and diabetes rates are rising.
And the inherited diseases.
These are generally rarer. Hemochromatosis is one example. The body absorbs too much iron. It's more common in people with Northern European roots. Symptoms like fatigue or a sort of bronze skin tone might appear around age 40. That iron overload damages the liver, leading to cirrhosis and cancer risk. There are others, like Wilson's disease. If a genetic cause is found, screening kids in the family becomes important.
Okay, that's a lot of potential pathways to liver damage. Given all that, is there anything people can actually do to lower their risk?
Yes, definitely. Material highlights several things. If you have chronic Hep B or C, getting treatment is number one, work with your doctor to control or cure the virus. Avoid risky behaviors that could lead to new infections. For alcohol, if there's dependency, seek help. And certainly avoid heavy drinking if you already have liver issues.
Makes sense.
For inherited diseases, it's about close monitoring with a specialist. Managing diabetes and obesity through lifestyle changes and medical care is also key. And interestingly, the source notes that Even after an HCC diagnosis, treating the underlying cause like suppressing Hep B or managing cirrhosis symptoms can improve overall liver health and maybe even prevent a second primary liver cancer from forming later.
Right, tackling the root cause is always beneficial. So if someone knows they have these risk factors, how would they find out if they actually have cancer? Is screening recommended?
Screening is absolutely key for high-risk groups. The source material suggests anyone with those established risk factors should be screened. That means chronic Hep B or C, significant alcohol history with liver damage, relevant family history for genetic diseases, maybe certain environmental exposures with liver problems. And many doctors now recommend close watching for obese or diabetic patients, especially if they have fatty liver showing up on tests.
And the goal of screening is?
Early detection. Simple as that. Find the cancer when it's small, localized, before it spreads. Because that's when treatments like surgery or transplant have the best chance of being curative. If you wait for symptoms.
It's often too late for a cure.
Often much more advanced, yes, and harder to treat effectively.
Why is it so hard to catch early without screening? Why don't people feel it sooner?
This is a really crucial point the book makes. The liver itself doesn't have many pain nerves. Only the outer layer, the capsule, does. So a tumor can grow pretty big inside without causing any pain. And second, the liver has this incredible reserve capacity. It can keep doing its job surprisingly well, even when a fair amount of it is damaged or replaced by tumor. So routine blood work might look totally normal for a long time, even with a growing cancer.
So you could feel fine, have normal blood tests, but still have early liver cancer.
Exactly. That's why proactive screening, looking for it before symptoms, is so vital for those known to be at high risk. Now, the book acknowledges that the absolute proof of screening benefit from huge trials isn't perfect, but the strong consensus among doctors is that finding it early offers the best shot at a cure.
Okay, so for someone getting screened, what does that actually involve? What tests? How often?
Well, the exact schedule is still debated and researched, so there isn't one single global standard. But a common approach, recommended by many experts according to the source, involves seeing a liver specialist regularly, maybe every 3 to 6 months. This usually includes standard liver blood tests and also checking the AFT level, that's alpha-fetoprotein, a tumor marker, maybe twice a year. And then a liver ultrasound, usually once a year.
AFP and ultrasound, and if something looks off on those screening tests,
Then that triggers the next steps, more detailed diagnostic tests to figure out exactly what's going on and confirm if it's cancer.
okay, let's talk diagnosis. If someone does start having symptoms, what might they actually feel?
Often the symptoms are actually signs of their underlying cirrhosis getting worse. Because the tumor is growing in an already damaged liver, it pushes the liver function over the edge, you could say.
So, symptoms of liver failure, essentially.
Pretty much. Things like abdominal swelling from fluid that's ascites, swelling in the legs and feet, edema, yellowing of the skin, and eyes jaundice because the liver can't process bile properly. That can also cause pale stools and dark urine.
Uh-huh.
And then there's the brain fog, confusion, forgetfulness, drowsiness, even personality changes. That's encephalopathy, caused by toxins like ammonia building up because the failing liver can't clear them.
That sounds really serious.
It is. And another potentially dangerous symptom is bleeding from varices. Remember the high pressure in the liver veins, portal hypertension? It can cause veins in the esophagus and stomach to swell up if they rupture.
They bleed.
Yes, causing vomiting blood, sometimes looking like coffee grounds or black terry stools. That's a medical emergency.
Okay, so whether it's found via screening or because of symptoms, how do doctors confirm it's HCC?
The next step is usually imaging, most often a CT scan or an MRI. CT uses X-rays for cross-sectional images. MRI uses magnets. Both usually involve injecting a contrast dye to make things clearer.
Is there a special kind of CT for liver cancer?
Yes, the source highlights a specific type called a triphasic or four-phase CT. It takes pictures at different times after the contrast is injected, looking at how blood flows into and out of the liver and any suspicious mass. HCC often has a very characteristic pattern of blood flow on these scans.
Are other tests used too?
Yes, that AFP blood test we mentioned for screening is also part of the diagnostic workup. A very high AFP level, especially combined with those typical CT or MRI findings, makes HCC very likely.
Is a biopsy always necessary then, to get a piece of the tissue?
That's the ultimate proof, yes. Taking a small sample with a needle for the pathologist to look at under the microscope. But interestingly, the source says sometimes it's not done.
Really?
If the imaging is extremely characteristic of HCC and the AFP level is very high, The book mentions over 400 doctors might be confident enough in the diagnosis to skip the biopsy and proceed directly to treatment, especially if surgery or transplant is planned.
Okay, so when would they definitely do a biopsy?
Usually, if the imaging isn't perfectly clear-cut or the ASP isn't that high, also it's generally done before starting local treatments like embolization or before systemic therapy like targeted drugs or immunotherapy.
Why is it important then?
Well, to be absolutely sure, it is HCC and not something else masquerading as an out. Also, sometimes the biopsy can give information about the tumor's specific genetic makeup, which might guide future personalized therapies. And it confirms the diagnosis before starting treatments that have significant side effects. The book also reassures people that biopsies don't cause the cancer to spread, though they do carry some risk, especially if cirrhosis is very advanced and affects clotting.
And what does the pathologist find out from that tissue sample?
They examine it carefully. They can confirm, yes, these are cancer cells. They can assess how aggressive they look. They confirm it's primary HCC originating in the liver. And they also look at the surrounding liver tissue to see if cirrhosis is present and how severe it is. All that gets summarized in the pathology report.
Getting that diagnosis must be overwhelming. One of the first things people probably wonder is about prognosis. What does the material say about how long someone might live?
It's a very tough question, and the book is honest. There's no single answer. It depends heavily on so many things. The stage of the cancer, obviously, the person's overall health, but crucially, the health of the rest of the liver, how bad the cirrhosis is, and, of course, the treatment options available and how the cancer responds.
Lots of variables.
Huge variables. Doctors can give estimates based on groups of similar patients, but individual outcomes can really differ. The source stresses how important a close, trusting relationship with your medical team is for navigating the fear and uncertainty that naturally comes with this.
And that cirrhosis, it keeps coming up. How much does the liver's underlying health impact things after the diagnosis?
Massively. The source calls it two diseases in one, the cancer of the cirrhosis. In some cases, the severity of the cirrhosis actually dictates survival and limits treatment options even more than the cancer stage itself. Yeah. So decisions about cancer treatment are always made with the degree of cirrhosis firmly in mind. That's why a hepatologist, a liver specialist, is almost always involved alongside the cancer doctors. They often use scoring systems, like the Child-Pugh score, to grade the cirrhosis severity.
Okay. Beyond the direct medical treatment, what about other kinds of support? Dealing with the emotional side, practical stuff?
Supportive care is absolutely vital. It's about addressing the whole person, not just the disease. That includes managing symptoms like pain, addressing nutritional needs, but also tackling the huge psychological, social, spiritual, and financial fallout that a cancer diagnosis brings. Life gets turned upside down.
So a team approach again.
Definitely. The material really advocates for a multidisciplinary supportive team, pain specialists, nutritionists, psychiatrists, or counselors, social workers. Comprehensive cancer centers are often set up to provide these integrated services. Integrative medicine is also mentioned, combining conventional treatments with complementary approaches to help with stress, well-being, emotional needs.
With all these specialists involved, what about getting a second opinion? Is that recommended?
Strongly encouraged, according to the source. It can give you more information, maybe different perspectives, and increase your confidence in the treatment plan.
Could the opinions clash?
They might, yes. The book acknowledges this. Liver cancer treatment can be complex, and sometimes there isn't one single right answer, especially for borderline cases. This actually reinforces the value of those multidisciplinary team meetings we'll talk more about, where different viewpoints are discussed.
Is there a downside to getting too many opinions?
Yeah. The caution is not to get bogged down seeking endless opinions. That can just cause confusion and delay starting necessary treatment. A second opinion is probably most valuable early on, especially if major treatments like surgery or transplant are on the table, as expertise can vary between centers. Maybe less critical if the disease is very advanced, but still potentially helpful for peace of mind. And importantly, talk to your main doctor about it. They usually understand and may even suggest it. It's about your comfort.
Facing this diagnosis must stir up so many difficult emotions: fear, anger, maybe guilt. How does someone cope with all that?
The material validates all those feelings: fear, denial, anger, guilt, depression. They're normal, expected reactions. It takes time to process. Talking openly about fears with doctors and loved ones is encouraged. And interestingly, learning more about the disease can actually help reduce fear, give a sense of control.
What about anger or guilt?
Anger is common, sometimes directed at others. It's important to remember family is going through it too and needs support. Guilt can be particularly strong if the cancer seems linked to lifestyle, like alcohol or past drug use. The source calls guilt normal, suggests acceptance is key, and even shares an inspiring story of a patient who turned his experience into becoming a counselor.
And depression seems almost inevitable.
It's a very real risk. And tricky because symptoms like fatigue or poor appetite can overlap with cancer symptoms or treatment side effects. The source lists signs to watch for and really stresses discussing feelings with the care team and seeking professional help. Psychiatrists, social workers, spiritual advisors can all play a role.
Okay, shifting to practicalities.
Hmm.
Insurance, finances, that must be a huge source of stress.
Absolutely critical and often overwhelming. Cancer care is incredibly expensive, and being sick impacts work, income, insurance. The advice is, sort out your insurance information immediately. Know your coverage, networks, premiums, keep records of every conversation. Hospitals usually have patient financial services staff who can help navigate this.
What about time off work, disability?
Yes, explore sick leave, short-term and long-term disability options through your employer, any private policies you have, and government programs. Things like Social Security disability, Medicare if eligible, possibly Medicaid, VA benefits for veterans.
And the cost of the drugs themselves, especially the newer ones.
That's a major point. Those biologic and targeted therapies can be extremely costly. Understanding your prescription drug coverage early on is crucial to avoid delays in starting treatment. Don't hesitate to ask your doctor or hospital staff about patient assistance programs or other resources. They often exist.
Okay, let's really dive into the treatments now. You mentioned different categories. What are the main ways doctors try to treat HCC?
Right. The source breaks it down into a few main strategies. First, trying to remove the tumor completely. That's either through surgery to cut out just the part of the liver with the tumor that's liver resection or partial hepatectomy, or the most definitive removal, replacing the entire diseased liver with a healthy donor a liver transplant.
And if removal isn't possible?
Then the focus shifts to destroying the tumor locally without taking it out. These are ablation techniques. Things like blocking the tumor's blood supply via hepatic artery embolization, sometimes with chemo added, that's TAE or TACE, or radioembolization using radioactive beads, or using heat, radiofrequency ablation RFA, or cold cryotherapy delivered via a probe, or even injecting alcohol directly into the tumor.
Okay, removal or local destruction. What's the third category?
That's systemic therapy. These are drugs that travel throughout the body via the bloodstream to fight cancer cells wherever they are. This is used when the cancer is more advanced, maybe it didn't respond to local treatments, it's too widespread in the liver, or it has spread outside the liver, metastasized. This category includes biologic or targeted therapies, immunotherapy, and traditional chemotherapy.
You mentioned the multidisciplinary team deciding the strategy. How does that work in practice? How do they choose between, say, surgery versus embolization versus systemic drugs?
This is where that team approach is so vital for liver cancer. It's complex, right? You've got the cancer specialists, surgeons who do resections, transplant surgeons, interventional radiologists doing the local procedures, medical oncologists managing the drugs, maybe radiation oncologists, and you've also got the liver specialists, the hepatologists, managing the underlying cirrhosis.
So they all meet.
Yes. The source describes these multidisciplinary tumor boards or meetings, where all these experts review a patient's specific case together. They look at the scans, the biopsy results, the liver function tests, the patient's overall health. They discuss the pros and cons of different options.
Can you give an example?
Sure. Like if a patient has a single small tumor and relatively mild cirrhosis, resection might be the top choice. But if they have very advanced cirrhosis, even with a small tumor that fits the criteria, transplant might be better. If the tumor is too big or in a bad spot for surgery, but still confined to the liver, then maybe TACE or RFA is the way to go. If it's already spread outside the liver, then systemic therapy is usually the primary approach.
So it's really tailored.
Exactly. It ensures all angles are considered. And the book shares that really telling story from Sam Howell about his father. Initially, resection was planned. But during evaluation, the surgeon realized the cirrhosis was worse than thought. The case went back to the multidisciplinary team, and they decided on embolization and alcohol injection instead. That controlled the cancer for years and maintained his quality of life, something Sam directly credits to that team discussion. It really shows the value.
Let's look closer at resection, cutting part of the liver out. What makes a tumor resectable?
Several things have to line up. First, the patient needs to be healthy enough overall for a major operation. Second, the remaining liver has to be healthy enough to function and regenerate. This is a huge issue with cirrhosis. You can't safely remove as much liver if it's badly scarred because the risk of failure is too high. You might remove 80% of a healthy liver, but much, much less if it's cirrhotic.
What else matters?
The cancer itself, its size, location, how many tumors there are. Ideally, it's a single tumor, or maybe just a few small ones. And its relationship to critical structures like major blood vessels, the hepatic artery, portal vein, hepatic veins, and the bile ducts. Can it be removed safely without damaging those? Sometimes they might even find during surgery that it's spread more than scans showed, or it's stuck to something vital, making resection impossible.
Okay. And what about liver transplant? You mentioned strict criteria.
Yes, the most common are the Milan criteria. Basically, a single tumor no bigger than 5 centimeters, or R, up to 3 tumors, none bigger than 3 centimeters. And crucially, no sign the cancer has invaded blood vessels or spread outside the liver.
Why so strict?
Because if the cancer is bigger or more widespread, the risk of it coming back after the transplant is much higher, meaning the patient doesn't get the long-term benefit from such a major procedure and scarce resource. Other factors matter too: age, other major health problems, active substance use, other recent cancers. Sam Howe's father's history of colon cancer, even though treated, impacted his transplant eligibility, according to the story.
Where do the livers come from?
Usually from deceased donors, cadaveric transplant, though sometimes a living person can donate part of their liver.
What's it like being on the waiting list?
It involves regular checkups to monitor everything. Sometimes patients get local treatments like TACE while waiting to keep the tumor within the criteria. But there's always the risk the tumor could grow too big or liver failure could worsen, making transplant no longer an option.
And the transplant operation itself.
If a suitable deceased donor liver becomes available, it's a rush to the hospital. The surgery is long, 4 or 8 hours. Recovery involves ICU time, maybe 1-2 weeks in the hospital total, and then lifelong immunosuppressant drugs to prevent rejection.
Okay, let's switch to those ablation techniques destroying the tumor locally. Tell me about embolization TACE.
Right. Hepatic artery embolization, TAE, or chemoembolization, TACE if chemo is added. The interventional radiologist threads a catheter into the hepatic artery branches feeding the tumor and injects tiny particles. These block blood flow, starving the tumor. If it's TACE, the particles also release chemotherapy right at the tumor site. It's for unresectable tumors confined to the liver. Can often be repeated.
And RFA or cryotherapy, heating or freezing.
Exactly. Radiofrequency ablation, RFA, uses heat from a probe inserted into the tumor. Cryotherapy uses extreme cold. These are often done percutaneously through the skin, but sometimes laparoscopically or during open surgery. They can actually be curative for small tumors, under 3 centimeters usually, sometimes a bit larger, an alternative to surgery for some.
What about alcohol injection?
Injecting pure alcohol directly into the tumor. It works best on softer HCC tumors within a firm cirrhotic liver. Used less now because RFA often works better, but still an option sometimes.
And radioembolization, radioactive beads.
Yes, yttrium-90 microspheres, sometimes called therasphere or SIR spheres, delivered via the hepatic artery like TATIA, but they emit radiation locally to kill tumor cells. It's for more locally advanced disease within the liver, not if it's spread elsewhere. The source notes its role compared to systemic therapy is still being studied.
Okay, that covers local treatments. Now, systemic therapy, the drugs, what are the main types again?
So these are for more widespread disease or when local options aren't suitable. The goal is control, improving survival, not usually cure in advanced stages. We have biologic or targeted therapies, immunotherapy, and traditional chemotherapy.
Tell me about the targeted therapies.
Drugs like sorafenib, Nexivar, and lenvatinib, Lenvima, are the main first-line choices right now. They target specific pathways involved in tumor growth and blood vessel formation. If the cancer progresses, other targeted drugs like regorafenib, Stivarga, cabozantinib, Cabometyx, or ramucirumab, Cyramza might be used next. The doctor chooses based on the specific situation and latest data.
What are the side effects like for those?
They definitely have side effects. The source details common ones for drugs like sorafenib and regorafenib. A big one is hand-foot skin reaction, redness, swelling, even painful blisters. Diarrhea and fatigue are very common too. High blood pressure needs monitoring. Less often things like hair thinning, rash, appetite loss. Serious but rare risks include bleeding or gut perforation. Managing these side effects with dose adjustments, creams, supportive meds is really important for staying on treatment.
And immunotherapy.
Drugs like nivolumab, Opdivo, work differently. They unleash the patient's own immune system against the cancer. Their side effects are often immune-related, the immune system attacking normal tissues, causing things like colitis or hepatitis.
What about traditional chemotherapy? Is it used much?
Less so as a standard first option now, according to the source and major guidelines. Doxorubicin was used early on. FO-LVOX, a combination, is used more, especially in some regions. PIAF is a more intense combo, but quite toxic, not routine. Chemo side effects often involve bone marrow suppression, low blood counts causing fatigue, infection risk, bleeding risk, which is especially tricky with underlying cirrhosis.
You mentioned a Mediport for chemo sometimes.
Yes, it's a small device implanted under the skin, usually in the chest, with a catheter going into a large vein. Makes for access easier and more comfortable for frequent treatments or continuous infusions. Does carry risks like infection or clots.
With all these options, how do doctors track if a treatment is actually working?
It's a combination of things. How is the patient feeling? Are symptoms better or worse? What does the physical exam show? Blood tests are key liver function tests, and watching the AFP level, does it go down? And then imaging CT or MRI scans, usually every 2 to 4 months, comparing them over time to see if tumors are shrinking, stable, or growing.
What role do clinical trials play? Are they an option?
Clinical trials are essential for developing new treatments. They test investigational drugs for approaches in different phases, phase 1 for safety, 2 for effectiveness, 3 comparing to standard care. Participation can be complex, though. Trials have very strict eligibility criteria, health status, liver function, prior treatments. Not everyone qualifies for a specific trial.
So being ineligible isn't necessarily a dead end.
Not at all. It just means that particular study isn't the right fit. Your doctor is the best resource for finding out about potentially relevant trials. Websites like clinicaltrials.gov list active studies. Sam Howe's story again shows how patients can be proactive in looking for trials, even if eligibility ends up being a barrier. New things are always being tested, like a SAR-T therapy mentioned in the source.
Okay, we've covered so much medical detail. Let's talk about managing the practical side. It sounds like information overload is common. How do people handle that?
It's totally normal to feel overwhelmed. The book validates this. The advice is, take notes, but focus on the big picture. Don't get lost in every tiny detail. And crucially, identify one doctor on your team, maybe the oncologist or hepatologist, who can act as your primary contact, your coordinator. The anecdote in the book about the author's mother struggling with conflicting advice from multiple specialists really drives home the need for that central point person.
What about diet? Any specific advice for liver cancer patients?
Generally, no magic cancer diet. Balanced nutrition is key. But with liver cancer and cirrhosis, there are specifics. As cirrhosis worsens, protein might need to be limited to manage encephalopathy, risk that confusion. It's a tough balance, meeting protein for strength but avoiding too much ammonia buildup.
Anything to avoid.
Definitely eliminate alcohol. High-dose vitamins or intense herbal supplements are usually discouraged as they can stress the liver. If there's fluid retention, ascites, edema, salt, and sometimes fluid restriction are needed. A dietitian specializing in liver disease is really helpful here. The source shares relatable stories about taste changes, difficulty swallowing, balancing healthy foods with small treats to keep appetite up.
You mentioned jaundice and fluid buildup earlier. How are those managed?
Jaundice, yellow skinnies from bile buildup, might be helped if it's a blockage that can be stented open. Otherwise, it's managed by treating the underlying liver issue, though it can be tough. Fluid buildup, ascites edema, is treated with diuretics, like spironolactone, Lasix, and low salt. Sometimes fluid needs to be drained from the abdomen, paracentesis. Low platelets are also common with cirrhosis, increasing bleeding risk and potentially limiting some treatments.
And the emergency bleeding situation varices.
Yes, variceal bleeding is an emergency. Vomiting blood, black stools, needs immediate ER visit, transfusions, and endoscopy to find and treat the bleeding veins, usually by banding them or injecting medication.
What about the mental confusion, the encephalopathy?
That's managed primarily by reducing toxin buildup from the gut. Lactulose, the laxative, is key. It helps flush things out and changes the gut environment. Sometimes restricting dietary protein is needed too. Any change in mental status needs prompt reporting to the doctor.
A quick reassurance: can family members catch the cancer?
No, HCC itself is absolutely not contagious, but the underlying cause might be. If it's Hep B or C, family might need screening for the virus. If it's a genetic disease, children should definitely discuss screening for that specific condition.
We're nearing the end of this deep dive, a difficult topic, but necessary. What happens if treatments stop working?
The source handles this sensitively. Doctors might recommend stopping active anti-cancer treatment if it's clearly not working anymore, if the liver is too weak, or if side effects outweigh any potential benefit.
It's not giving up then.
Absolutely not. The book frames it as protecting the patient from harm. shifting focus. The anecdote about the author's father stopping ineffective treatment really emphasizes this pivot towards quality of life, doing no harm.
So what is the focus then?
Best supportive care? It's still active care, but focused entirely on comfort. Managing pain, nausea, fatigue, fluid, jaundice, whatever symptoms arise. Regular doctor visits continue, but the goal is maximizing function and well-being, allowing time for family, hobbies, spiritual needs. Maintaining hope and a positive outlook is still crucial.
And hospice often comes into play here.
Yes. Spiritual for the patient and family. Usually when life expectancy is limited and curative treatment is stopped, it can be at home or in a facility. The source shares a very moving story about how hospice relieved the burden on the family, providing expert care and allowing them quality time, even though accepting it was emotionally hard initially.
To ensure wishes are followed.
Yeah.
Advanced directives.
It's essential. Legal documents stating your wishes if you can't speak for yourself. A living will details what medical interventions you would or wouldn't want, like CPR or ventilator. Discussing DNR, DNI, do not resuscitate, intubate, orders early is important, especially with advanced cancer where such measures might just prolong suffering. Sometimes doing less is more. The other part is the healthcare proxy, appointing someone you trust to make decisions for you. You must talk to that person about your values and wishes. Informing your family also prevents conflict later. Your care team or a social worker can help with these forms.
The final question in the book is profound. Preparing to die. Where is hope found?
It acknowledges the fear, but reframes preparation as a way to shape this final life phase, not give up. Practical steps help. Sorting finances, wills, focusing on relationships, visiting loved ones, reconciling issues, sharing memories, passing on meaningful items, preparing funeral wishes can bring closure. The biggest fear is often leaving loved ones. The advice is connection. Spend time, create tangible memories like photo albums or letters, be abundant with life, focusing on meaning and moments.
And hope.
Hope shifts. It's not necessarily for cure, but for quality time, connection, acceptance, peace. The preparation itself can be a source of hope and control. The anecdote about Francis advising the author to tell his father, "I love you," early and often, is incredibly powerful, highlighting that connection is where hope resides, even at the very end.
If people want to learn more after this.
The source points back to doctors, cancer centers, reliable websites like the NCI's, cancer.gov, clinicaltrials.gov, but it strongly cautions about random internet info. Check sources. Discuss everything with your doctor. Chat rooms can offer support, but use info consciously. Comprehensive cancer centers often have many resources. Just ask.
This has been incredibly thorough. We've gone from the very basics of liver cancer through risks, detection, the complex web of treatments, the vital role of support, coping strategies, and even facing end of life with preparation and hope.
Yeah, the source material really provides a roadmap for understanding this challenging journey, emphasizing knowledge, communication, and holistic support.
We really hope this deep dive has given you, our listener, clarity and valuable knowledge drawn from these specific questions and answers. Living with liver cancer often means tackling both the cancer and the underlying liver disease, navigating tough choices, and finding that balance between fighting for time and preserving quality of life.
So the thought to leave you with is this. How does arming yourself with knowledge, seeking out that comprehensive support network, and fostering those truly honest conversations with your doctors and your loved ones empower you to face that complexity and discover your own sources of hope along the way?
Something to reflect on. Thanks for joining us on the deep dive.